Hi, Dental XP members. I'm Dr. Stephen Goldstein from Scottsdale, Arizona, and today I would like to talk about my clinical perspective on choosing ceramic materials for posterior or anterior implant restorations. This is from a talk that I gave at the AO meeting in 2012. Here are my goals for any ceramic material. First, I'd like them to be biocompatible and provide long-term health to the implant, to the tooth, and of course the periodontium. I'd like them to be durable over a long period of time. 10 years for me would be great. I'd like them to be as aesthetic as possible. I'd like an average dental technician to be able to fabricate them easily in the laboratory. I'd like the materials to be non-technique sensitive in the dental operatory, meaning if we could cement, that's easier than bonding. And of course, I'd love the materials to be repairable, especially if you have a layered material and the layering ceramic chips. It would be nice if it was easily repaired with composite. At this point in time, I don't think there is any one particular material that could meet all of these objectives. I think there are many factors that go into the selection of ceramic materials, and for me, I've divided it here into thirds. Number one, it's my experience with the material, so that the dentist's experience with any particular material matters. I also want to know with my laboratory what materials they're experienced with. And I think that the patient is another component of the picture, which we don't talk about a lot, but I will address shortly. Here are some current papers from the dental literature, and there are volumes and volumes of papers on ceramic materials, each listing the pros and cons of a particular material. And what I find is it's very difficult to draw a definitive conclusion on which ceramic material is the best. Here are some quotes from the papers shown in the previous slide, and if you read through them, you'll find it's very confusing to select a ceramic material. In addition, the literature doesn't have a clear definition for what constitutes a failure. So, if I cement or bond a crown, say a lower molar, in a patient's mouth, and in a year the porcelain on the lingual cusp slightly chips, is that considered a failure? For me, if I can smooth the area and the crown is still functional and aesthetically pleasing to the patient, then it's not a failure. If I need to replace the crown, then I consider that a failure. This is a gray area in the literature and needs to be addressed. You'll also notice that the PFM has been the gold standard over the last 50 years, and that is the crown or the material that all the new ceramic materials will be compared to. Here's a slide I put together showing material failures. And no, these are not all my cases, but some of them are, and there are no materials that are indestructible in dentistry today. Even the gold crown with the hole in it needed to be replaced due to recurrent decay. As I mentioned from the literature, the PFM has been the gold standard for the last 50 years. This is a slide from Glidewell Laboratories, and if you look, in 2007, of all the crowns they made, 65% were PFMs and 25% were all ceramic crowns. Now jump up to 2011 and you can see of all the crowns they made, 65% are all ceramic crowns and 27% are PFMs. I believe this trend is due to the aesthetic demands of the patients and the doctors over time, as well as the cost of metal has gone up substantially over the last couple of years. Also note the increased use of monolithic zirconia. Glidewell and some other licensed laboratories have produced over 1 million Bruxer crowns in the last 2 years, and I think that trend will continue as well. With all that being said, you may ask, are PFMs dead? And in my opinion, no. I personally don't use as many PFMs as I used to. However, my indications for using PFMs would be to match existing porcelain fused to metal crowns. So in this particular case, the patient has had a full reconstruction done with PFMs, and now the lower right segment needs to be replaced with implants, and I'm going to use PFMs in this case on metal abutments to restore the lower right side. Let's take a look at the doctor requirements for using any ceramic material. As I choose a material, I want to know the manufacturer's requirements for using that material. So what I'll do is go to the website and download the tooth preparation guide. Here you can see for zirconia, this is from Lava, 3M's product, you can see the space requirements for the material. And this is important because the laboratory is going to need a particular amount of space to provide you with a restoration that won't fracture. So if we need 1 millimeter or 2 millimeters reduction and we give the laboratory less than that and the material fails, that's not the fault of the material, that's the fault of me. So I always want to know that I am providing at least the recommended amount of space for the material that I'm using. In this next slide, you can see here's the preparation guide from Ivoclar for Emax. And again, if you're going to make a full crown and it requires 1 millimeter thickness at the margin, then we need to provide that for the laboratory, as well as for the survival of the material. So these are handy guides. Most of us know this, but every time a new material comes out, they may vary. So it's really important to at least start out knowing exactly the amount of room that we're required to give for the laboratory. When it comes to abutment design, I only use custom abutments. If you look at the photo here of some stock abutments, it's very difficult to choose an abutment that is going to be exactly what you want for your particular case. The reason is one size does not fit all. It's actually easier for the doctor to have the laboratory fabricate a custom abutment than it is to pick out the part from the catalog. You can precisely design the margins. I personally like to have the lingual margin supragingival and the facial margin slightly subgingival, so that if I cement the restoration, I won't introduce cement into the sulcus. You'll also see in some of the upcoming slides that I customize my impression coping so that I'm actually capturing the sulcus that was formed by the provisional. And again, I'll show you that shortly. And then modifying stock abutments is not easy, nor is it free. If you ask your laboratory to modify a stock abutment, they will charge you a fee to do that. And typically what I've found is a stock abutment doesn't contain enough bulk of material to carve it down. So typically my sulcus might be wider than the actual stock abutment material, which is why I've never used one. Also, what I've never done is drilled on the abutment in the mouth, because sparks will fly out of the patient's mouth, which for me is not a big practice builder. Plus, I want the laboratory to have the actual part in their hand when they're fabricating the crown, which will allow both pieces to fit precisely. So again, I wouldn't take an impression of a custom abutment in the patient's mouth and then have the laboratory fabricate the crown. I don't think the fit will be as precise. Here are some additional items that we should all have in the dental office. Of course, the proper ceramic chemicals are important, and they should be fresh and current, not materials that have been sitting around for months, and then when you go to use them, they have expired or they're not effective anymore. We also need a sandblaster. That's a very important piece of equipment, as well as a steam cleaner. I could not live without my steam cleaner for cleaning, for example, like an abutment prior to inserting it into the mouth. I want to know that every single part that I'm going to place into the patient's mouth is very, very clean and free of debris. Now, most laboratories will sandblast and, of course, steam clean abutments, let's say, prior to sending them back to your office, but sometimes there'll be little bits of debris in the screw head, or there might be some residual polishing material left on an abutment. So it really is in our best interest, and of course the patient's interest, for us to be able to clean the parts very well in the dental office. And so again, I couldn't live without my sandblaster or my steam cleaner. We also have to know how to use the chemicals properly for the particular ceramics that we're working with. So for example, when I etch feldspathic porcelain, I will use 10% hydrofluoric acid for 90 seconds. That's very different than etching Emax or lithium disilicate. You can use the same 10% hydrofluoric acid, however, you only want to etch that for 20 seconds. If you over etch lithium disilicate, you can damage the material and you won't have the bond strength that is obtainable by doing it properly. The dental laboratory is a great source of information, especially with respect to ceramic materials. So before I would select any material for any particular case, I would want to know the following information from my laboratory technician. Number one, what ceramic materials are currently available at the laboratory? I would like to choose a material that is already in the laboratory that the technicians are familiar with. Then I'd want to know what ceramic material does the laboratory technician work best with. In other words, what are his favorite materials? So if I have an aesthetic case that requires matching, let's say, a single central incisor, there might be a ceramist that works really well with feldspathic porcelain. Or a different ceramist might work better with, let's say, lithium disilicate. So they each have their favorite materials, and I'd like to know always from them what would they choose for a particular material. I'd also like to know what are the specific protocols and instrumentation for adjusting a particular ceramic material. What I would like to be able to do is chairside adjust, let's say, the contact of a crown and not damage the material. So I'm always interested in how the laboratory technician would do it and with what instruments. I also want to know how can we easily and efficiently communicate. I don't have time throughout the day to stop what I'm doing and answer a phone call. Most of the time, I will communicate with my laboratory early in the morning or after work via email. And we do that using a color-managed digital workflow. Here's a photo of some of the instruments that I use to adjust various ceramic materials, and this came from my laboratory. So what I've done is gone down to the laboratory and I've watched the technician adjust various materials, and then I purchased the identical instrumentation so that when I am in my office and I need to modify a ceramic workpiece, I can do it similarly as the technician would. My goal is to be able to adjust a material and get the same result as the technician would. I also use the Brasseler red stripe diamonds, they're 40 grit, and the yellow stripe diamonds, which are 20 grit for intraoral modifications of the ceramic materials. I never use coarse diamonds to adjust ceramic materials because that will damage them and sometimes irreversibly, which could of course lead to failure. So anytime I want to adjust a ceramic material in the mouth, I'm using either the red stripe 40 grit diamonds or the yellow 20 grit. When fabricating frameworks for layered restorations, the laboratory will need to design the frameworks properly, just as they did with porcelain fused to metal crowns. So here you can see a zirconia frame. It's CAD/CAM design being built on a computer, and they need to provide support for the layering feldspathic porcelain. Once the cores are milled, then the material is gently sandblasted. And of course, the laboratory needs to know the correct coefficient of thermal expansion for the zirconia and the feldspathic porcelain. And I think that over the years, my technician has gotten this down very well because we are not experiencing the chipping problems that have been reported in the literature. So we've made many layered zirconia crowns over the years with pretty high success. The third component that we need to address when choosing a ceramic material is, of course, the patient. And they come in many different shapes and sizes like most other things in life. What I've done here is I've grouped various patients into low, medium, and high-risk groups for material failure. The group on the left is considered the low-risk group because they have very little occlusal wear. They have more of an ideal occlusion. They are very kind to their teeth, and typically any material that we choose to use in these patients should work for a really long period of time. The middle group, upon examination, you would notice aberrant planes of occlusion, substantial wear. However, you won't see a lot of fractured porcelain. These patients, they're beating up their teeth, but they're not destroying the materials. You might see, like in the patient in the center, a diastema form. Again, they're tough on their teeth, but they're not really fracturing the ceramics or their restorations as much as the group on the right. The group on the right, the high-risk group, is the group that scares me the most because I don't know if we have materials that could survive long-term in these patients. They are really tough on their teeth, and you'll see fractured ceramics. You might even see fractured metal frameworks. These are the patients that scare me because I don't know if the materials that we have today could survive long-term in these particular patients. With that being said, how do I choose a ceramic material for a particular patient? Mock-ups and provisionals are really the key to successful dentistry. A mock-up gives the doctor and the patient a preview of the final case, or they get to see what's possible. The provisionals allow both the patient and the doctor to evaluate the case and allow the case to be modified prior to choosing a ceramic material. So if I have a patient that is really tough on provisionals and breaking the provisionals, I might choose a different ceramic material, maybe a stronger one than, say, a feldspathic material or a weaker one. And then also, this allows the laboratory technician to copy the provisionals instead of design with ceramic materials. Designing in ceramic materials is costly and very difficult to adjust once the case was returned from the laboratory. So I never want my laboratory technician to design something without some sort of a guide or, of course, a provisional to copy. Then there are no surprises at the end of the case, and typically the patient leaves very happy. Now I'd like to go through some cases, show you my workflow, and then show you how I choose the final ceramic materials. Here's a case of a young, healthy girl who was congenitally missing her upper right lateral incisor. If you look at the x-ray, you can see we have the appropriate amount of space, 6-7 millimeters, to place an implant. And the image on the right shows the implant has been placed, healed, and now the patient returns to my office. For me, this is my starting point. And my goal now is to develop the soft tissue site appropriately with a provisional restoration. The first thing I'll do is place an impression coping in the implant and, of course, x-ray the coping to be sure that it's fully seated. And I'll fabricate a soft tissue model and a provisional restoration. In this case, I used methyl methacrylate jet acrylic, and I'm a big fan of that in a lot of cases because it's very easy to adjust or manipulate in the mouth. The provisional looks good, however, the soft tissue does not. We have an aesthetic problem where the papilla is not filled in. And if you look at the pre-op x-ray, the interproximal peak of bone looks normal, and I feel, and I hoped in this case, that the papilla would fill in. So what I really need to do is give it some time. So I would see the patient maybe every other week and evaluate the area to see if the papilla will start to reform. Here's about 3 months with the provisional, and the tissue is starting to look good. It's not fully mature, but it's definitely moving in the right direction. If the tissue wasn't improving, then I might need to do additional procedures, say bond some composite to the distal surface of the upper left central incisor to increase the length of the contact area, or possibly change the shape of the provisional, but I would need to do something to eliminate the unesthetic area. This case did work itself out. The tissue did come back and it looks quite good. Now notice the interproximal peak of tissue is not going to be the same length as the contralateral incisor. However, it still fills the space and aesthetically it's pleasing. Once the provisional is removed, you can see there's a beautiful soft tissue profile. And now my goal is to capture this exactly so the laboratory can fabricate a soft tissue model and know the exact shape and the volume of material required for the custom abutment. Let me show you how I do this. Although this is a different case, it's the exact same principle. What I do is I'll place an impression coping into the implant, and then I will quickly use ultra-dense block-out resin. It's their blue block-out material, and I will inject it into the sulcus, forming a custom impression coping. So the provisional is removed, I place the impression coping and quickly inject this material. You can also use flowable composite if you'd like. I've been using this for years, so it works for me. It sticks nicely to the impression coping, and I've never had one fall off. And I'm fabricating a custom impression coping. This material, now it's light cured, will support the soft tissue so that I don't have to hurry and take my impression, because for every minute or so that the provisional is not in the mouth, that soft tissue starts to collapse. So what I'm trying to do is support that tissue with a flowable light cured material. Once the material is light cured, and this whole process takes less than a minute, then I'll take an x-ray to confirm that the impression coping was seating. If I do it the other way, take the x-ray first and then apply the material, too much time will have gone by and that soft tissue will actually start to collapse. So I place the material first, light cure it, and then I take my x-ray. You can see here when the impression coping is removed, the ultradent material will stick to the coping, and as I said, I've never had one fall off. Then this goes to the laboratory and they pour a soft tissue model, and this exactly represents the patient's soft tissue. So now I can have the laboratory fabricate a custom abutment, and I know that the margin placement is going to be just about dead on compared to the patient. And if it's not, it can be very, very easily adjusted, but there's not going to be a gross amount of adjustment required. I use a two-stage impression technique with polyvinyl siloxane, and on my website there's a paper on how I do this. You can download the PDF file, read it, and you can see how I technically do this procedure. And it's very easy to do. This is the kind of thing, if you haven't seen this procedure before, it's really easy. It makes a lot of sense and something that you'd be able to do right away. Now the case has been impressed, and when the provisional was removed, it went back into the laboratory. It was cleaned in an ultrasonic cleaner. I also removed the screw from the provisional. I want the parts to be able to be cleaned separately. Then they're dried. I polish the provisional, and then everything is steam cleaned prior to being replaced in the mouth. And then I also place a little bit of Concepsis in the body of the implant and on the screw, so that everything is clean prior to me sealing the screw access hole of the provisional. Now the case is sent to the laboratory, and they will fabricate, in this particular case, a custom zirconia abutment and a zirconia core. And so since they have the soft tissue model, it's pretty easy for them to figure out the shape of the custom abutment. Once that's done, then the laboratory can apply porcelain. This is feldspathic porcelain here being applied, and of course fabricate the final restoration. In this case, I really feel that the technician should help select the material, because since it's a low-risk case to me, I want them to pick a material that they work with the best to achieve the highest aesthetic result possible. So here, there's no compromises that we need to make, because I don't feel the patient is going to fracture the porcelain. And I'd like the technician to pick a material that they work best with. So in this case, it was a milled Velan zirconia core with Noritake feldspathic porcelain. And this is our go-to restoration if we want to achieve the highest aesthetics. Here's an image of the patient showing the final restoration. This case took 6 months to complete, and that's because it took a few months to develop the soft tissue site with the provisional. I will never go to the final restoration until the provisional and the soft tissue are as good as they can be, because that gives me the most predictable results for the final restoration. So if this case took 4 months or 5 months for the provisional phase, so be it. I just know I want to go into the final restorative phase with everything, like I said, as good as it could be. Here's a close-up of the final case, and I think the results turned out very nice. The ceramic material blends with the adjacent teeth. I'm happy with the soft tissue profile. Patient's happy, and I think ultimately she has a beautiful smile. Here are some images from 30 months post-insertion, and I still think the case looks great. The ceramic material blends beautifully with the adjacent teeth. Also note there's no chipping of the porcelain. It's just held up very well. And I think it's a combination of, again, the low-risk patient, the laboratory technician helping me choose the appropriate material, and one that they work very well with to achieve a really nice aesthetic result. Here's another example of a congenitally missing lateral incisor case. And again, this is also, for me, a low-risk case. And if you look at the pre-op images in the final case, you can see the restorations look nice. The soft tissue is very healthy. And this also was the same ceramic materials. It was Noritake feldspathic porcelain layered on a zirconia core. And here's a close-up of that case as well. This case is also a few years old now and, again, doing very, very well. Here's a case I did, and I would consider this a medium risk case. This patient came to me. He moved to town, and he had implants placed in the 8 and 9 site. He's wearing provisional restorations in the upper image and wants to have these teeth restored. And my first question to the patient was, do you like the diastema? And he said no. And so I had my laboratory fabricate a 4-unit wax up, including the lateral incisors. And I was able to take, in this case, Luxatemp in a Siltec matrix, and in about 6 minutes fabricate the mock-up that you see in the picture below and show it to the patient. The patient liked it so much that he asked me to photograph it, and what I did was email the image to the patient's spouse, allowing her to look at it. And then he came back in shortly after and said, I'd like to do all 4 restorations. So here you can see the preoperative image, the mock-up, and then the final restoration. And the final restoration should be similar, if not better, aesthetically to the mock-up. Here are the custom zirconia abutments on this particular case. Both lateral incisors were prepared for feldspathic veneers, and the crowns were fabricated from zirconia cores with, again, Noritake feldspathic porcelain. And what we like to do is, if we're going to make veneers with feldspathic porcelain, we like to make the crowns with the same material, because then they will look identical. And so I typically wouldn't use dissimilar materials for the crowns and the veneers. Here's an advanced case with a very complex occlusal scheme. These are the kind of patients that are in the high-risk category for fracturing ceramic materials. And with cases like this, I'm sure we can have lengthy discussions on what materials to use for these particular cases. Some of you might say PFM, some of you might say metal occlusal surfaces, and none of you would be wrong. Here is the pre-op Panorex, and you can see that this patient has had a lot of dentistry in the past. Also, the upper posterior segments were held in with denture adhesive, so they had completely failed. And what was difficult with this case was to decide which teeth to retain and which ones to remove. The team decided that we would keep the 2 central incisors and the upper left lateral incisor, which is actually a canine in the lateral site. And we did this because we thought aesthetically it would make a significant difference. Here you can see the initial provisionalization of this case. I removed all the existing upper crown and bridge work and placed provisionals on teeth numbers 8, 9, and 10, which is really 11, and a removable prosthesis was fabricated for the posterior segments. Due to the complex nature of this case, what I wanted to do was build a prototype and see how the patient did with the implant-supported provisionals. So a final impression was taken. You can see that's the image on the left. And then I had the laboratory take titanium temporary cylinders and flow composite over them, forming custom provisional abutments. And then we made heat processed provisional restorations that cement over the provisional abutments. And so basically what this is a mock-up of the final case, allowing us to evaluate the emergence profile, the aesthetics, the occlusal scheme, etc. And I allowed the patient to wear this for a few months because I wanted to see, is anything going to break? Is she having any issues functioning, etc. So this was a lot of work. However, I felt it's very necessary to do this prior to fabricating anything with ceramic materials. This method also allows the laboratory to copy the provisionals and of course enhance them versus creating a case, especially this large of a case, in ceramic materials without some sort of a guide. So the provisionals and the custom abutments really were the prototypes for the final case. Metal abutments were chosen in this case for strength. This case will have individual units. I chose not to splint anything. And to block out the metal, we chose zirconia. You can see here the metal abutments being tried in, and their shape was based on the provisional abutments. And you can also see the zirconia cores tried over the natural teeth, ensuring they block the light. And here's an image of the final case. And I think this is a beautiful case aesthetically for a bunch of reasons, but I think probably the best decision we made was to keep the natural teeth 8, 9, and of course 11 in the 10 position. I think that really sets the frame for the rest of the case, and the patient's smile line covers the margins of the posterior teeth, which are longer. However, it allows the beautiful centrals and the laterals to show, and it really makes this case very pretty. Here's the pre-op photo and the post-op photo with the lower case completed as well. And you can see there's a very complex occlusal scheme going on here. And there's a crossbite. The patient has a very unique envelope of motion. And that was all worked out in the provisional restoration so that when the ceramic materials were fabricated, again, we copied that scheme and the patient functions very, very well with this occlusal setup. The final restorations were zirconia cores, again with Noritake feldspathic porcelain. That's the material that we like the best for creating single aesthetic crowns. Now, I mentioned that the case was not splinted. If anything were to break or chip, it's very easy to replace a single unit versus a splinted restoration. The lower anterior restorations were veneers. Those are teeth numbers 23 through 26, and they were the same material, of course, as the layering feldspathic porcelain on the crowns. Here's an x-ray of the final case showing 16 implants, 22 crowns, and 4 veneers. This case took approximately 2 years to treat. You can see the timeline and the steps involved from the preoperative image to the provisionals and then the final case. Every medium and high-risk case that I construct gets an occlusal guard. It's just part of the case. And in some cases, I've actually made 2. So if the patient loses one, I have a backup ready to go. So I really want them to protect the ceramics at all costs. Here's a case of extreme wear with 2 posterior mandibular implants, and I had been treating this patient for quite a while, and he was never interested in restoring his full mouth. However, he had 2 implants, and you can see the screw access holes in the gold crowns, which weren't there originally. This patient is a severe bruxer, and I would say once a year approximately, he would loosen the screws on the abutments of those crowns, necessitating me drilling through them and replacing the screws, retorquing them, and then patching the crowns with composite. So this went on for a couple of years until finally, when his anterior teeth started to erode, he became interested in restoring his mouth. For this case, I had many discussions with colleagues, laboratory technicians about what material to use in this environment. And these cases really scare me because they're large, they're complex, and I don't want to do anything that's irreversible or that I can't repair fairly easily in the future. A Hawley bite plane was used to determine the vertical dimension. The patient wore that for a few weeks, and then based on the wax up, a Siltec was made, and Luxatemp was placed into the Siltec, and that was positioned in the patient's mouth, and I had an instant mock-up for him to view. He liked the way it looked, and then what I decided to do was spot bond each tooth and bond the Luxatemp in the patient's mouth and let him go for a couple of weeks just to see if he can function at this vertical dimension. Is the occlusal scheme working? And I was really curious, will he fracture the Luxatemp material? I chose Luxatemp for this case because it's a more brittle material than methyl methacrylate, and I wanted to see, as he bruxes, will this material fracture? This was like a trial run for me where I'm able to develop the occlusal scheme, I'm able to show the patient what this could look like aesthetically, and see if the Luxatemp material will survive for, let's say, a couple of weeks. As it turned out, it did, which gave me the confidence to go forward with this case. I also felt strongly about not removing additional tooth structure. He had a lot of wear from the start, and I felt I'd like to try to preserve as much natural tooth structure as possible, which led me to the direction of bonded restoration. So I thought in this particular case, instead of removing tooth structure and crowning all these teeth, why not preserve what he has, because he has a lot of enamel around the dentin in most of these teeth, and why not use that for making bonded restoration? So this case led itself to using a material such as lithium disilicate, and in this case Emax. What's also nice is that the preparations were minimal. Here in this image you can see the minimal preparations, and what I try to do is smooth the enamel and have no sharp line angles. And you can see the final impression of the lower posterior implant supported units being taken here. Here's the final case with Emax restorations, and for the implant restorations, I decided to make them screw retained. I changed my mind at the last minute because I felt, since he's loosened the abutments many times over the years, if that happens again, it'll be much easier for me to retrieve the screw and replace it with a screw retained unit versus cutting through Emax in the mouth and trying to repair it that way. So I had the laboratory fabricate a custom metal abutment. It was opaque, and then the crown was fabricated with a screw access hole. You can see the green polyvinyl siloxane plug there, and that will be removed, trimmed, and then a composite restoration will be bonded to close the screw access hole. So that allows me in the future, if this crown or abutment becomes loose, I could easily remove the composite, replace the screw, and just repair that single unit. Here are the lower 4 restorations in place, and again these are bonded restorations, all single units, and you can see the green PVS plug has been cut and the composite will be placed shortly. In this case, I inserted the lower posterior restorations in one appointment, so that's the lower left and the lower right. Then I inserted the upper left and the upper right in the next appointment. And then we chose, in this case, feldspathic porcelain for the veneers. I know it's a dissimilar material, but in this case, with the conservative tooth preparations, we didn't have a lot of space, and we can make feldspathic porcelain veneers very, very thin. And also, again, my laboratory technician feels very comfortable with that type of restoration, and so I felt comfortable as well letting him do that, even though we're mixing the anterior and posterior ceramic materials. So here we have the final case with the bonded posterior restorations made from Emax and the anterior 6 upper and lower veneers made from feldspathic Noritake porcelain. You can see the before and the after images, and what I like about this case and feel really good about is that they're all single units. It's a very conservative reconstruction, if you will, and if anything fractures or breaks in the future, I'm really going to be repairing, hopefully, just single units. Here's the timeline. This case took about 8 months to treat, and you can see the pre-op images, the provisionals, which were, again, Luxatemp bonded for approximately a month to test the occlusal scheme and to see if the material would fracture. Of course, this case gets an occlusal guard, and this is one where I actually made 2. So if he loses one or wears through one, I want him to immediately be able to use the second one, and I'll repair or replace the first one, because I think a case like this, it will require maintenance over time. I'm just trying to mitigate that, and he's placed on a 3-month recall, so we see him every 3 months. His hygiene's really good now, and this case has been going well. In summary, diagnose the environment that the ceramic materials will reside in, and test your diagnosis with provisional materials. Don't get married to one particular material and try to use it for all your cases. Learn the physical requirements of the selected materials that you choose and how to specifically handle them in your office. You might need to purchase appropriate equipment so you can adjust and modify ceramic materials equally as good as your laboratory would, or you might already have those materials available. Work very closely with your laboratory and understand how ceramic materials are fabricated. If possible, go visit your laboratory and actually watch the technician use the particular materials. I always protect my ceramic cases, especially the medium and high-risk cases with occlusal guards. They're included in the fee of the case. And of course, follow the literature and monitor your own personal results. I'd like to thank you for watching this video and for Dental XP for allowing me to present this. If you have any questions, you can email me personally if you'd like to at the email address above, or post a comment on Dental XP. Thanks. I'd like to personally thank my good friend and ceramist Rick Durkee at Lafayette Dental Laboratory for the construction of the ceramics on all the cases that were shown today. Thanks again, Rick.